Next, we have Dr. SRUTHI who will be talking on a comparative study of the characteristics and the outcome of web of versus non-web of features in children.
A very good morning to one and all. So my paper is on pediatric orbital fractures. I don't have any financial disclosures, and consent for clinical photographs have been obtained from our patients. It is wise to say that children are not young adults. Why? Because the pediatric and adult orbital fractures are different due to the difference in bony skeleton. The adult bone is rigid due to progressive calcification, but the pediatric bone is immature and is more elastic. So what happens after a pediatric orbital fracture? The elastic pediatric bone snaps back into place, leading to entrapment of the orbital soft tissue as well as fat and muscle, which is fondly called the trapdoor fracture. Simply put, pediatric orbital fractures are broadly divided into number 1, white-eyed blowout fracture or WEBO, where there is no external periocular signs of trauma. WEBO is easily overlooked. Why? Because a child usually presents to the emergency OPD with nausea, vomiting, oculocardiac reflex, syncope and all that. So this will sort of confuse the doctor in the emergency, making him, think of intracranial injury, and he may advise radiology to the, head, and it can eventually lead to delayed diagnosis. The second type of pediatric orbital fracture is a non-white-eyed blowout fracture or non-WEBO. It can be seen in isolation, like in blowout fractures with periocular trauma, or it can be seen in association with more complex fracture patterns, including zygoma, maxilla, and nasoethmoid fracture complex along with the orbital complex. Blowout fractures clinically present to us with diplopia, enophthalmos, and paresthesia of the infraorbital nerve. Now, there are very few studies which have analyzed the incidence and the outcome of pediatric orbital fracture on the Indian subcontinent, though the case load and the variety of pediatric orbital fracture is surplus in our population. So, this was a lacuna in literature. So this made us basically aim at comparing the characteristics and the outcome of white-eyed blowout fracture versus non-white-eyed blowout fracture in children. It was essentially a retrospective interventional study of 38 pediatric patients with orbital fractures between the time period of June 2015 to June 2022 and was conducted at the LV Prasad Eye Institute, Hyderabad. We included patients who were less than 18 years of age with a definitive diagnosis of orbital fracture with at least one follow-up visit, and we excluded patients who were more than 18 years of age who had an intracranial injury and who had no follow-up after initial presentation. We did a detailed EMR or electronic medical record analysis of our patients. We also pulled out the CT, which was basically uploaded and linked along with the files of our patient. We looked at the morphology of the fracture. We looked at enophthalmos. We looked at extraocular muscle entrapment or impingement or herniation into the fracture. We also had got the institutional review board approval for our study. The parameters looked at was a demographic data, the mode of injury, the clinical presentation, intraocular and periocular involvement, the time from injury to surgical intervention, the surgical approach used, the implants used for fracture repair, etc. Now, a good outcome was defined post-operatively as no diplopia in primary gaze, and number 2 as a very good, enophthalmos correction, which is basically difference in Hertel's exophthalmometry of less than 2 mm between both the eyes. Out of the 38 pediatric orbital fractures, we saw that 21 had WEBO and 17 had non-WEBO. We were also surprised to see that male preponderance was there in the ratio of 5:1. And the overall mean age was 11.87. It was also interesting to see that the white-eyed blowout fracture category had a younger mean as compared to the non-WEBO category. Right eye was more commonly involved as compared to the left eye. Another interesting finding was that oculocardiac reflex was seen in 33.3% of the white-eyed blowout fracture category. We also saw that accidental fall was the most common mode of injury in WEBO category, while road traffic accident was the most common mode of injury in non-WEBO category. The implant used most commonly was elastic sheet in white-eyed blood fracture, while titanium was the most commonly used implant in the non-white-eyed blood fracture category. While when we did a bivariate analysis, the occurrence of a white-eyed blood fracture pattern and WEBO configuration, that is basically the absence of multiple wall fractures, were actually related to a good outcome. But when we did a multivariate analysis, no factors were basically statistically significant. This could possibly be due to smaller sample size. Good outcome was seen in 95.23% patients of WEBO category, and a good outcome was seen in 66.6% patients in the non-white-eyed blood category. So there are a lot of studies which were done abroad, but as I already suggested, there was a lacune that the Indian studies were not much. A similar study done in 2018 by Mukherjee et al. Was in line with this, and they had found out that road traffic accident was the most common mode of injury in pediatric orbital fracture, and the most common implant used in their study was porous polyethylene. So to conclude, the prevalence of presentation with ocular cardiac reflex seen in 33.3% of white-eyed blood fracture was one of the interesting outcomes that we saw in our study. The most common mode of injury of white-eyed blood fracture was accidental fall. A good outcome was seen in 95% of WEBO as compared to 67% of non-WEBO. We also saw that white-eyed blood fracture category children were having a lesser mean age as compared to non-WEBO. The outcome of fracture repair is better in patients with WEBO as compared to non-WEBO, possibly due to distortion of orbital, anatomy in WEBO is lesser, and fewer orbital walls are involved, and probably due to the earlier presentation of these kids to our emergency OPD. So multimodal collaborative studies are basically needed to come to a better algorithm for pediatric orbital fractures in our country. And of course, this requires a lot of patience, persistence, and perseverance. Thank you so much.
Why WEBO presented early? Because
yeah, so the child has syncopal attacks, the child has nausea, vomiting. So when all these things, the parents get sort of, worried, and they bring the child earlier.
because I would have expected non-WEBO, which has really
So
some injury, should come earlier than WEBO.
probably it could also be because we are an ophthalmic setup. So these non-WEBO category mostly would have gone to other multi-specialty hospitals. So this was an interesting finding that we saw when.
So WEBO came to you directly without reference.
Yeah.
And what is the follow-up? You said only one visit you included. What is the maximum follow-up you would have had?
No, only the first initial presentation. If they had come, we usually did not include.
But after the one visit,
multiple, because if some patients have undergone surgery, then multiple. So we.
How many? How much mean follow-up?
Post-operatively 3 more, because that is how we see the patients. First day, then after 2 weeks, then after 2 months. Post-operatively, yeah.
Post-operative. Yeah.
Okay.
So that's why I'm asking, what is your follow-up? Yeah. What are the complications after developing WEBO? I mean, treatment. Like, what are the complications?
Yeah, so the first of all, because of edema, the diplopia can still persist. But by 2 weeks, 3 weeks, the edema, everything resolves, and they are usually fine. So that is one thing that we see. And then we tell the parents to, give rest to the patient so they don't go to school very soon. After 2 weeks, they can start going to school. Yeah.
What I meant was your patients with double vision, thanks to your surgery, also can report later than 2 months.
Okay.
If your average follow-up is going to be only 2 months, you cannot use no diplopia as an outcome measure, is all that.
Okay.